Welcome to the Deep Dive. We're your guides today, ready to tackle a condition that can really knock you sideways, vestibular neuronitis. We've got a listener's revision notes here.
We do indeed. And the plan is to take this, potentially dense MSRA material and make it super clear, high yield, and hopefully much easier to remember for revision.
Exactly. Think of it as taking the core facts about vestibular neuronitis, what it is, why it happens, how you spot it, what you do, and just locking down the essentials.
We'll walk through it systematically, hitting the definition, causes, features, how to manage it, pulling out those key nuggets from the notes.
Okay, let's dive in then. Vestibular neuronitis. All right, first things first. According to these notes, what exactly is vestibular neuronitis? What are we talking about?
Okay, so at its core, it's defined as a sudden inflammation, specifically of the vestibular nerve, the nerve that's crucial for our sense of balance.
Right, the balance nerve. And when that gets inflamed,
It leads directly to acute vertigo. The notes describe it as typically unilateral, so one side affected, usually pretty severe, but often something that gets better on its own, spontaneously resolves.
spontaneous resolution. Okay, that's good news up front. And the notes mention it often follows something specific.
Yes, very commonly it appears after a viral infection, especially things like upper respiratory tract infections, colds, flu, that sort of thing.
Got it. And are there other names floating around for it, just so we recognize them?
Yeah, the notes list a few synonyms you might see: vestibular neuritis, acute vestibular syndrome, sometimes idiopathic acute vestibular dysfunction. Pretty much the same thing in this context.
Okay. So vestibular neuronitis is the nerve. Now, how does that differ from labyrinthitis? The notes seem to make a point about this.
Yeah, and it's a really important distinction. Labyrinthitis is similar, causes vertigo, balance issues, but the key difference is it affects both the vestibular nerve and the labyrinth itself.
Ah, the labyrinth. That's the inner ear structure.
Exactly. Includes the cochlea for hearing and the vestibular system parts. So with labyrinthitis, you can get hearing symptoms too, which you typically don't get with just neuronitis. That difference is crucial later.
Okay, so inflammation of the nerve. Why? Why does it suddenly get inflamed? What's the etiology here?
Well, for vestibular neuronitis specifically, the notes point to something quite interesting. A likely cause being reactivation of the herpes simplex virus, HSV.
Wait, HSV, like the cold sore virus. That's not what I'd immediately jump to for vertigo, so it's not always just a generic post-flu bug.
That seems to be what the evidence in these notes suggests is a primary link, yeah. Perhaps reactivation happening in the vestibular ganglion, the nerve cluster. Though they do also mention possible roles for autoimmune processes or maybe microvascular issues. Other theories exist.
HSV reactivation. Okay,
Yeah.
that's a key takeaway.
Mm.
And labyrinthitis, different cause.
Also, often viral, yeah, frequently following those URTIs again. But, and this is important, the notes highlight that bacterial labyrinthitis, while much rarer now because of antibiotics, can happen. It's dangerous and often linked to anatomical problems or other infections spreading.
So does anything make someone more likely to get vestibular neuronitis? Are there specific risk factors listed in these notes?
This is another slightly surprising point, actually. The notes are quite explicit. There are no specific risk factors identified.
Really? None at all. That seems odd for an inflammatory thing.
I know, right? But they do immediately add the caveat that having a recent viral infection or URTI may increase the risk, which, fits perfectly with the suspected HSV or viral link we just discussed.
Okay, that makes more sense. So how common is this? What's the epidemiology say, maybe for the UK?
The precise prevalence isn't totally clear, according to the notes, but it's definitely considered a common cause of peripheral vertigo. Affects all age groups.
Common. Any numbers to give us a rough idea?
Well, they quote a wide range for vestibular dysfunction diseases generally, like 3% up to maybe 35%. For vestibular neuronitis itself, the incidence seems to go up with age, peaking around 40 to 50 years old. Something like 3.5 cases per 100,000 in that age bracket.
Okay, so middle age seems to be the peak time. And labyrinthitis. Similar pattern.
Viral labyrinthitis is also common in adults, maybe 30, 60 years old, also peaking in that fourth decade, so 30s, 40s. The notes mention it might be a bit more common in women. Bacterial labyrinthitis, the rare one, has different patterns, meningogenic type, mostly in very young kids, under 2, while the autogenic type linked to ear disease can happen at any age.
Right, we know it's inflammation of the nerve. What's actually going wrong physically? The pathophysiology.
It's pretty straightforward, really. The notes describe inflammation and swelling of the vestibular nerve.
And that swelling just messes things up.
Basically, yes. It disrupts the normal signals that nerve is supposed to be sending to the brain about your head's position and movement. It's like static on the line or the line being cut from one side.
Which directly causes.
The brain gets conflicting or missing information from the two inner ears. It can't make sense of it, and that mismatch triggers the intense feeling of spinning, the vertigo, plus the nausea and imbalance that go with it.
Okay, let's picture the patient. Someone walks in. What are the classic signs and symptoms? What history clues are we listening for?
The absolute main thing is that sudden onset of severe vertigo. And the notes stress this isn't just a quick dizzy spell. It lasts for days, sometimes weeks.
Wow, days to weeks of intense spinning. It sounds absolutely awful. What else comes with it?
Nausea, vomiting are very common. A real sense of imbalance, difficulty walking straight, or even standing. These tend to go hand in hand with severe vertigo.
Any other features to note? Anything else they might describe?
Well, sometimes people might report recurrent attacks before the big one, lasting hours or days. And on examination, you'll typically see horizontal nystagmus, that rapid, involuntary back and forth eye movement.
Horizontal nystagmus, okay. And crucially, the notes really highlight what's absent in VN, which helps tell it apart.
Yes, this is super high yield. In classic vestibular neuronitis, there should be no hearing loss and no tinnitus, no ringing in the ears. This is a major differentiator from labyrinthitis, where because the labyrinth, including the cochlea, is involved, you can get hearing loss or tinnitus.
Right, that nerve only versus nerve plus labyrinth distinction again showing up in the symptoms. What else is key in the history?
You really want to pin down the vertigo. Is it constant? Yes, for VN, it usually is, though moving might make it feel worse. How bad is the nausea? And definitely ask about that recent viral illness, the URI. It's a common preceding event. Fever might be present, but a high fever could suggest something else, maybe more serious.
Gotcha. History covers vertigo character, associated symptoms, recent illness. What about the physical exam? What are we looking for?
A good exam is vital. You need to look in the ears, check the eardrums, do a cranial nerve exam, especially checking hearing. Feel behind the ear for mastoid tenderness. Check for neck stiffness, ruling out spread of infection. Watch how they walk, how's their gait. They often veer or fall towards the affected side with VN, and you'd perform simple hearing tests like Weber's. Then, critically important, you do the head impulse test checking that vestibulo-ocular reflex. Observe the nystagmus type carefully, and look for skew deviation. Are the eyes vertically aligned?
And that exam is so key because, as you said, vertigo can mean lots of things, some much more serious. What else is on that differential diagnosis list? What are the scary things these notes say to consider?
Absolutely critical step, this. You must rule out other causes. Common differentials include BPPV, benign paroxysmal positional vertigo, Meniere's disease, and of course, labyrinthitis.
And then the ones that really need urgent attention.
Yes. Central causes. Stroke, particularly in the cerebellum or brainstem, is top of the list. But the notes also mention things like vestibular migraine, Ramsay-Hunt syndrome, that's shingles affecting the ear nerve paralimb fistula, TIAs, meningitis, MS, brain tumors, acoustic neuroma, even rarer things like carbon monoxide poisoning or Wernicke-Korsakoff. It's a long list.
Whoa, okay. That really highlights why you need a quick way to tell VN or labyrinthitis apart from something like a stroke. The notes mention the HINTS exam for this.
They certainly do. The HINTS exam is a fantastic bedside tool. It's specifically for patients with acute continuous vertigo to help differentiate peripheral causes like VN from central ones like stroke. HINTS stands for Head Impulse Test. Nystagmus analysis. Test of skew.
Okay, HINTS. Break it down for us. What pattern suggests VN labyrinthitis and what pattern screams stroke?
Right. According to the notes, the pattern strongly suggesting a peripheral cause like VN or labyrinthitis is an abnormal head impulse test, meaning the eyes slip off target and correct. Unidirectional horizontal nystagmus always beats the same way, away from the bad ear, and no vertical skew deviation. That combination is generally reassuring.
Abnormal impulse, unidirectional nystagmus, no skew, likely peripheral, and the danger signs for stroke.
The concerning pattern is a normal head impulse test. This is counterintuitive but very sensitive for stroke in this context. Bidirectional nystagmus changes direction with days, or purely vertical distortional nystagmus, and the presence of vertical skew deviation. Any one of those dangerous features in a patient with acute vertigo syndrome should make you think central cause, like stroke.
Wow, okay. Normal head impulse test being a bad sign in this context is definitely something to remember. And the notes also flag sudden hearing loss with the vertigo as another potential stroke sign.
Exactly. New hearing loss plus acute vertigo should raise suspicion for ischemia, maybe of the inner ear artery or brainstem. And one last point from the notes here. The Dix-Hallpike test for BPPV is not the test to do for someone with constant vertigo, like in VN or labyrinthitis. Wrong test for the job.
Okay, so you've done the history, the exam, the hints points towards peripheral.
Mm-hmm.
What investigations are actually needed? Do we need scans on everyone?
The notes are pretty clear here. The diagnosis is primarily clinical, based on that history and the physical exam findings, especially hints.
Mostly clinical then, yeah.
For a typical case, absolutely. Blood tests, rarely helpful unless you're suspecting a systemic infection or something specific, maybe an FBC or blood cultures then, but they don't diagnose VN itself.
And imaging, CT, MRI.
Generally not needed for straightforward VN. A CT might come into play if you suspect a complication like mastoiditis spreading from the ear. An MRI is really reserved for when you are worried about those central causes, stroke, tumor, MS perhaps because the HINTS exam was worrying, or there are other neurological signs.
So scans are more for ruling out the mimics, not confirming VN. What about specific hearing or balance tests?
Definitely need formal audiometry if there's any hint of hearing loss to quantify it and help differentiate VN from labyrinthitis or other causes. More specialized vestibular function testing, things like caloric tests, ENG, VEMPs, can give detailed info on nerve function and might help with prognosis, but they're often done later by specialists. Portable video oculography is also mentioned for precisely measuring eye movements.
Right, clinical diagnosis made. How do we actually manage vestibular neuronitis? What's the treatment strategy?
It's mainly about two things: relieving those awful acute symptoms and then helping the body recover its balance function.
Symptom relief first. That vertigo sounds unbearable.
It really can be. For severe acute cases, the notes suggest things like buccal or IM prochlorperazine for quick relief. For milder symptoms, a short course, and short is key, of oral prochlorperazine or certain antihistamines like cinnarizine, cyclosine, or promethazine can help manage the vertigo and nausea.
Okay, prochlorperazine or antihistamines, but you stress short course.
Yes, absolutely critical point from the notes. You need to avoid using these vestibular suppressant drugs for too long. Why? Because the brain needs to undergo vestibular compensation. It needs to adapt to the faulty signal from the affected ear. These drugs can actually slow down or prevent that vital recovery process.
Makes sense. Just enough to get through the worst, then let the brain do its work. Did the notes mention anything not recommended?
They did. Specifically mentioned as not routinely recommended for VM are antivirals, benzodiazepines, and corticosteroids.
Good to have those don'ts clear. Okay, beyond meds, how do people get better? You mentioned compensation.
Yes, and the key to promoting that is vestibular rehabilitation exercises. The notes strongly recommend these, particularly if symptoms linger or just to speed up functional recovery once the worst is over. Getting the patient moving, doing specific head and eye exercises helps retrain the balance system.
Like physiotherapy for the inner ear balance system.
Kind of, yeah. Exercises designed to help the brain adapt and use other senses like vision and proprioception to recalibrate.
When should we be thinking about urgent referral or bringing someone into hospital?
Definitely need immediate referral or admission if there's that sudden unilateral hearing loss happening with the vertigo. The notes flag this as a potential vascular emergency, like ischemia of the inner ear or brainstem. And of course, any worsening symptoms, or if new neurological signs pop up, that needs urgent medical attention right away.
Any role for surgery in VN?
Not typically for vestibular neuronitis itself. The notes mention surgery like myelinotomy or mastoidectomy might be needed for some labyrinthitis cases, especially the bacterial ones, to deal with infection. But VN is usually medical management and rehab.
And important advice for patients going home.
Yes, the notes are clear. Advise them strongly against driving or operating heavy machinery while they're actively vertiginous or taking those symptom relief meds, as they definitely impair function.
So what's the usual story long term? What's the prognosis like for vestibular neuronitis?
For most people, the outlook is pretty good. They tend to see gradual improvement over weeks to months. The really severe vertigo and nausea usually calm down within days to maybe a couple of weeks.
Weeks to months for full recovery, but the acute phase ends sooner. Is it always 100% back to normal?
Not always, no. The notes mention that some people might be left with some residual dizziness, maybe a subtle feeling of imbalance, especially with quick head movements. For labyrinthitis, if hearing was affected, recovery of hearing various bacterial labyrinthitis, unfortunately, often results in permanent hearing loss.
That hearing distinction again. What about impacts beyond just balance itself? Any of psychological effects?
Yes, the notes do mention that vestibular problems in general can be linked with issues like anxiety disorders, depression, and sometimes even cognitive difficulties.
Yeah, I can absolutely see how constantly feeling unsteady or dizzy would take a huge psychological toll. Are there direct physical complications of VN itself?
The main physical risks mentioned are falls and potential injuries because of the severe vertigo, especially early on. But probably the more common complication or associated issue is the development of that chronic anxiety, maybe depression, and just a general reduction in quality of life if symptoms persist or aren't managed well.
And if symptoms just seem to drag on forever or keep coming back?
Chronic or recurrent cases definitely warrant referral, according to these notes. Need to make sure nothing else is going on, no underlying cause missed initially.
Okay, we have covered a lot of ground. Thinking about someone revising for the MSRA, what are the absolute must-know high-yield nuggets? The memory hooks.
Right, let's boil it down. First, the key symptom differentiator. VN equals sudden severe vertigo, no hearing loss, no tinnitus, likely viral. Labyrinthitis, vertigo plus hearing loss, and tinnitus can be viral or bacterial. That hearing distinction is gold.
Hearing loss, think labyrinthitis or something else, not simple VN. Got it.
Exactly. Second, ruling out stroke is paramount. Remember the hints exam. Reassuring peripheral pattern, abnormal head impulse, unidirectional nystagmus, no skew, dangerous central pattern, normal head impulse, bidirectional vertical nystagmus or skew. Nailing hints is crucial for safety.
Hints, hints, hints. Got it. What else for management?
Keep it simple. Symptom relief, short-term only, prochlorperazine antihistamines. Avoid long-term vestibular suppressants because they hinder brain compensation. Push vestibular rehabilitation exercises early. And always have a low threshold for urgent referral if you see red flags like sudden hearing loss or new neuroscience.
Great summary. Recognize a pattern, rule out stroke with hints, short-term meds, long-term rehab.
That's pretty much the core framework, yeah. Keep those key points clear.
So wrapping this up, what does this deep dive really tell us? We've got vestibular neuronitis, common, often viral, causes horrible vertigo, but usually gets better with the right support.
What's really striking, I think, is how inflammation of just one small nerve can cause such profound disruption. But also how critical it is to have clinical tools like the HINTS exam to rapidly differentiate it from potentially devastating mimics like stroke based on subtle but specific physical signs.
It really underscores the power of careful clinical assessment, doesn't it? Recognizing those patterns and symptoms and exam findings to navigate a potentially confusing presentation. Definitely key knowledge to have solid.
Well, that was our deep dive into vestibular neuronitis, turning those MSRA notes into hopefully a much clearer revision aid.
Remember, focusing on those core concepts and differentiators is the way to go.
If you are prepping for the MSRA or just building your medical knowledge base, do check out pastthemsra.com for their comprehensive resources.
And don't forget freemsra.com for excellent free revision materials as well.
Thanks so much for joining us on the deep dive. We'll catch you next time.